Okay, it's your life.
Excellent. Wonderful. Well, good morning, everyone. It is a pleasure to see members of the Legislative Policy Committee here in October as we have this beautiful fall. We have an important meeting today, consistent with the bill that was passed several years ago regarding the upper payment limits for prescription drugs. We are here on the agenda today. We are going to hear from the Prescription Drug Board as well from DLS. There is not a period in this presentation to have open hearing, but we have written testimony that has been submitted and is available. DLS has summarized a lot of that written testimony, and all members should have a copy of those documents currently. And before we jump into the presentations, let me hand it over to Speaker Jones to see if she has any opening remarks.
Yes. Thank you, Mr. President. In 2019, the Maryland General Assembly passed legislation to create the nation's first prescription drug affordability board. The board was charged with examining the marketplace and determining whether we need to create upper payment limits on certain drugs which have become unjustifiably expensive. I want to thank Chairman Van Mitchell and Executive Director Andrew York for their diligent and methodical work to set up the Prescription Drug Affordability Board and begin examining the true costs of our prescriptions. Look forward to hearing about the details of the board action plan and doing our part to reduce the cost of prescription drugs for Maryland state employees and retirees. That's my opening remarks, Mr. President.
Wonderful. Thank you, Madam Speaker.
Sure.
Members, before we will have the two presentations. One will be from Andrew York, who's the Executive Director of the Prescription Drug Affordability Board, as well from Jennifer Chassie, who is the Principal Policy Analyst from DLS, who will be summarizing the report. I'd ask if we could just, if you could put your questions to the side. We'll have both presentations first, and then we'll open it up for questions and discussion at that point. So without further ado, let me hand it over to Mr. Andrew York.
Great. Thank you, Mr. President. Can everyone see our presentation? Great, thank you. Well, President Ferguson, Speaker Jones, and members of the Legislative Policy Committee, thank you so much for your time today. My name is Andrew York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board, and we are here to present on our Upper Payment Limit Action Plan. We're seeking approval from the Legislative Policy Committee. Sorry, I want to make sure, excuse me. There we go, sorry. We are seeking approval from the Legislative Policy Committee on our work so that we can begin our work setting upper payment limits for state and local government. Maryland's at the forefront of developing and implementing policies to make prescription drugs affordable for our residents, and the Prescription Drug Affordability Board is proud to be an important part of that work. I wanted to quickly start by thanking the board and the staff for their incredible work on putting this together, as well as our 26-member stakeholder council, which is a series of volunteers that represent the different parts of the prescription drug market. And then finally, I wanted to thank the public and the stakeholders for their amazing and robust feedback throughout this entire process. I had a couple of comments that I wanted to start with just about the upper payment limit action plan itself. The first thing I wanted to note is that upper payment limits are one tool in a larger process looking at how to make prescription drugs more affordable for Marylanders. In our action plan, the board will look at all policies that are available to make prescription drugs more affordable, but upper payment limits may be one of those policies that we can use. We look at it as one of the tools in the toolbox. Next, the action plan creates an extremely robust process that's transparent with significant opportunities for public comment and community engagement from patients, clinical experts, and other experts, because our UPL is going to be implemented through rulemaking. We require the board to publish a number of different intermediate steps throughout the process and allow for public comment at each of those steps. And then the rule will ultimately be published through notice and comment under the Maryland Administrative Procedures Act. Also, I wanted to just start by talking about what an upper payment limit is. It's a tool that addresses certain drivers that make certain drugs unaffordable. So for the purposes of our plan, we regulate state and local government entities, and we define the upper payment limit as the final net ingredient cost to the purchaser or payer, the governmental purchaser or payer. This is important because it allows flexibility on how we would work with governmental partners to implement the upper payment limit. And we expect that the way that it'll be implemented with the different payers is that it won't affect the Maryland supply chain. So pharmacies and hospitals, wholesalers likely won't see their reimbursement change at all. It's all, we are proposing that it be done all kind of on the back end through back end reconciliation through something called rebates. So that does address some of the concerns that have been brought up. Finally, reducing cost is all about increasing access. Being able to afford a drug is an essential part of being able to access the drug. So the mission of the board is to increase the affordability and ultimately increase access. The board must publish a monitoring plan to ensure that there are no unintended consequences and that upper payment limits will ultimately increase access to patients. And we have a number of different mechanisms and tools to ensure that upper payment limits are being implemented the way that the board intends. So with that, I'm going to give a quick background on the board itself. So as mentioned, the board was created in 2019, and it's an independent agency, dedicated to making prescriptions. It's a 5-member board supported by a 26-member stakeholder council that advises the board. And its purpose is to protect state residents, state and local governments, commercial health plans, healthcare providers, pharmacies licensed in the state, and other stakeholders within the healthcare system from the high cost of prescription drugs. And I'd like to read that purpose and mission just to show you all the different stakeholders that the board is working on behalf of. We have a 5-member board, and it is required that all members have expertise in healthcare economics or clinical medicine, and you may recognize some of these names. And the work that we've been doing kind of falls into 3 large buckets that I'll give brief overviews of before we dive into the upper payment limit itself. First, we have cost review studies, which is basically an in-depth review of selected drugs to determine if they cause affordability challenges. And our statute says that an affordability challenge is high costs to the healthcare system or high out-of-pocket costs for patients. So that's the definition of an affordability challenge per our statute. Also, the legislation references upper payment limits. And again, this is a policy tool that can address specific affordability challenges, and we need to implement it through the upper payment limit action plan that's before you today. And then finally, we can recommend additional policies. So a lot of the groundwork that our board had done was understanding and studying the pharmaceutical supply chain and understanding what causes certain prescription drugs to be unaffordable. We've made extensive study of the drug supply chain, and we published something called our supply chain report. And that included a number, it's about a 120-page document that goes through all the kind of market failures that are causing affordability challenges, and then the possible policy solutions that are available to the board. So this is a document that we'll refer to throughout our work, making sure that we are taking the right action. And then as part of this report, we found it was in the best interest of the state to move forward with setting upper payment limits. Just as a quick overview, we have been around since 2019. So the board was created in 2019, the board members were appointed. In 20 and 21, we spent time kind of standing up the infrastructure of the board and getting our funding. And then in 22, we started a lot of our initial work. So we worked on the drug supply chain report that I mentioned. We published a series of other reports. And in 2022, the board, July of 22, the board voted that it was in the best interest of the state to move forward with upper payment limits. And since then, we've been working on this work. So upper payment limits have been at top of mind of the board for years at this point. In 2023, we spent a lot of time developing our cost review study process, and the regulations were published at the end of 23. And in 2024, we brought to you the upper payment limit action plan, and then also we're currently engaging in our cost review study process. And in 2025, we look forward to continue our work. So just a very high-level overview, the cost review study process allows us to identify specific drugs and then understand if they're causing affordability challenges. In May of in March of 2024, the board identified 8 eligible drugs that they referred to the Stakeholder Council for input. In May of 2024, the board selected 6 of those drugs for the cost review study process. In July of 2024, after the July board meeting, we went through the data collection process. We did something called a request for information from manufacturers, carriers, payers, and pharmacy benefit managers and wholesalers. And right now we're in the process of actually analyzing that data and doing the cost review study, which we expect to conclude sometime this fall. These are the 6 drugs that are currently under cost review study for your reference. 4 of the drugs have undergone the request for information process, and then the final 2 will do a separate request for information when the staff is ready to process that information. And the reason I started by going through our cost review study process is because these 2 processes are related. The purpose of the cost review study process is to determine if the drug causes affordability challenges. And the way that our process currently works under our current regulations is that ultimately the board makes this determination. The board says a drug has led or will lead to affordability challenges or high out-of-pocket costs to patients or high costs to the healthcare system. But there is no kind of next step to that. And that's where this upper payment limit action plan comes in. So again, just providing the history of our work, the board made an 2022. Throughout 2023, you can see on the right that we made a series of presentations to the board and the Stakeholder Council for public input, talking a lot about the actual process, the actual substance of and merits of setting upper payment limits. In our supply chain report that we published, we have an entire section on, again, the background for work comparable to setting upper payment limits. And then in 2024, we went through the work of actually setting up the process itself. And that's what the legislation asks for. I'll go over this in just a moment, is that we publish an upper payment limit action plan that goes over the process. So we published a draft for the upper payment limit action plan that asks for public input. Those public comments were received. We received 22 comment letters and posted those on the website and shared with the board. Comments were reviewed by staff and changes were made for the board meeting on September 10th. And then ultimately the board approved the upper payment limit action plan and referred it to the Legislative Policy Committee, which is where we are today. So that's all the background information. So the couple key points that I wanted to point out. First, again, the legislation requires that we create this plan of action for implementing the process for setting upper payment limits, including the criteria the board should use to set those upper payment limits. Also, in setting public policy, the board is engaging in rulemaking by adopting regulation and setting the UPL. And this process provides full transparency and robust community engagement. And then finally, the upper payment limit action plan links to this cost review study process that I had just mentioned. And all of this allows the board to collect the information and review relevant information to set policy through rulemaking. So I wanted to start with just a high-level overview. And for today, the purposes of today's meeting and just time sensitivity, I am going to keep it at a very high level, but we do have the in-depth presentation. So I will seek guidance from the committee on if we want to get into the weeds on each step. But at a high level, the first thing we need to do is gather additional information. And this is going to allow for robust public engagement, especially from the patient community and the clinical community. Then, based on that information, the staff can recommend policy options. We're ultimately going to be looking at why is a drug unaffordable. The cost review study says that yes, a drug is unaffordable, but then this process actually looks at the why. And then the policy options can be non-UPL policy, which again, we think is just as important as the UPLs themselves. And if the staff and board decide to move forward with the UPL, we actually have a very specific process for how to set upper payment limits. And then ultimately, there's going to be final actions around all of these policy recommendations. The board can pass recommendations for non-UPL policy recommendations, and then also will ultimately publish regulations setting the upper payment limit for regulated governmental entities at the specified amounts, or some combination of both. You can do an upper payment limit and other policies, or kind of any combination of those. Let's see. So again, just going back to where this fits in the cost review policy process. So I mentioned the cost review policies, or the cost review study process that we're already doing. Basically, what the upper payment limit action plan does is it creates a preliminary determination. So the first thing the board is going to do is make a preliminary determination of if there's an affordability challenge or not. So this doesn't currently exist right now. It just kind of stops at that part. But what this does is it allows us to say, okay, we've identified that these drugs are unaffordable. What can we do about that? And that brings us into this policy review process. And I'll go through this in just a moment, but this is basically the board studying the issue itself and trying to make recommendations and help Marylanders by actually taking action to make those prescription drugs more affordable. So you can see here that we have our preliminary policy determination. This is going to be new as part of the upper payment limit action plan. This is what's implemented through the upper payment limit action plan. First thing is the board makes their preliminary determination. If the board says that this drug doesn't have any affordability challenges, that's the end of the action. We just publish a report that says we didn't deem this drug to be unaffordable. The next, however, if the preliminary determination is the drug does cause affordability challenges or may cause affordability challenges, then we start this brand new process that we've created through this report, which is our policy review process. So the first step is for the board to identify the drivers and recommend policy options. So it's very important that we are identifying why the drug is unaffordable and trying to make sure that the policies that we are considering are directly addressing the drivers of those affordability challenges. In our supply chain report, we talk about a number of different market failures, and there's different policies that you would use for different market failures. So we want to make sure that we're catering our policy recommendations to the exact circumstances and market context of the drugs that we're looking at. And there's two buckets here. There's the non-UPL policy options, which again is a very robust list, and I think will be fully vetted as part of this process. And if we decide to move forward with upper payment limits, there's the UPL policy options. So just going at a very high level, you can see the two processes that we have here. I'll go through the non-UPL process because it's a little bit shorter, but again, just as robust, there's just fewer required steps. First, the board staff identifies the drivers and identifies the policies that respond to those cost issues. We hear from a number of different stakeholders that, sometimes there are very specific policy failures or market failures that are causing the affordability challenge, and it has nothing to do with amounts that manufacturers are charging or anything like that. There's specific issues that we should look at. Well, as part of this process, we intend to look at exactly what is making prescription drugs unaffordable, cause high out-of-pocket cost to patients, or have high cost to the healthcare system. The staff, again, will provide those, propose those drivers and then the recommended policies to address those drivers. And then the board would then provide feedback. And this would be published for public comment. And then ultimately the board will provide feedback. The staff will then update the recommendations and draft resolutions based on public input and board feedback. And then ultimately there can be final action. And I'll address this at the end because the final action on both of these policies can happen at the same time. So that's what's happening for non-UPL policy options. That's going to be happening in a parallel circumstance to upper payment limits. So then if we go to upper payment limits, again, it's an upper payment limit action plan because we need to create the process for setting upper payment limits. And you can see from the report that we really did go into depth for setting very specific steps and requirements throughout. So the first thing that we need to do is our optional information gathering. And then the staff can recommend upper payment limits. Well, first, the staff needs to recommend that an upper payment limit is an appropriate tool to address the drivers that are causing the affordability challenge. And then we can also recommend different methodologies. And I do have a slide here that shows kind of the list of these kinds of methodologies, but each of the methodologies kind of, again, is responsive to different market conditions. So we want to make sure that whatever methodology we're using is being responsive to the driver that we've identified. So just a couple examples, you can look at cost effectiveness research, comparative effectiveness research, different kinds of reference pricing, therapeutic reference pricing, national reference pricing, those kinds of things. But there's a number of different ways that you can do that analysis. So the board will, or the staff will first start by saying, here's how we propose to calculate the upper payment limit. That'll be published for public comment. So the public gets to provide their input on just the overall framework. Should we set upper payment limits? And if so, we should use this general methodology to do so. The board then provides feedback and gives staff to the guidance to move forward. And then the staff will then actually calculate the amount based on the board input and the public comment. So we will take the methodology and produce numbers from those methodologies. And we'll be publishing that calculation and methodology for the public to review. And we expect pretty robust public comment as part of that process. And because this part of the process can get extremely technical, we also propose that the board may host technical meetings. So just for your reference, a lot of this work, often is designed around modeling that has certain assumptions that are baked into the models that come up with the equation or produce the outputs. And we expect that our colleagues, stakeholder colleagues, will want to weigh in on kind of each of those different issues. So we expect public comment to really be robust around the methodology, the calculations, and the assumptions that the staff is making. And then we can update those methodologies based on the public input. And then ultimately, any version that we are putting out will be subject to public input. So if we kind of iteratively put out one version and then the public provides compelling comment that makes it look like we need to update it, we would then publish another version that the public would then be able to comment. There's no scenario where it goes straight to the board without the public being able to really weigh in on every kind of assumption and decision that the staff is making. And then ultimately, we expect final action to happen for both of these processes at the same time. The board, or it can happen at the same time, it doesn't necessarily need to, but the board would ultimately adopt a UPL as a proposed regulation. It would set the amount. It would say the eligible governmental entities that we're working with. So we, the regulated governmental entities, we'd say which ones it would apply to, and then set timelines and describe exactly how it would be implemented. So that would all be done through notice and comment, which has its own robust opportunities for public input, and then ultimately would be finalized as a regulation. So that at a high level is how this process works. There are a number of nuanced details at each of these steps, but just trying to be respectful and responsive to time, I may leave it here, but depending on questions or if someone wants me to walk through any of the individual steps, I'm available to do so.
Excellent. Thank you very much, Mr. York. It was a very thorough and speedy presentation. And members, please write down any questions that you may have. Before we get to those questions, let's turn it over to Jennifer Chassie, who is providing a summary of the written testimony that the Legislative Policy Committee has received regarding this presentation.
Thank you. Good morning.
Good morning.
So this past Friday was a deadline to submit written testimony to LPC on the proposed plan. We received a total of 23 sets of comments from 23 different stakeholder groups, total of 77 pages of largely technical testimony, which we have tried to briefly summarize for you. You've all received the actual corresponding information from the individual groups. Overall, there's a combination of both support and opposition, significant suggested revisions, and some concerns and suggested alternatives to setting upper payment limits. And I'll just briefly go through this document for you. In terms of support, the overall comments were that the UPL process is being proposed by PDAB is among the most comprehensive to date. It was adopted unanimously by the board and will provide greater transparency. It serves as a landmark step in making prescription drugs more affordable and will help bring relief to government budgets and free up funding for other important public services. The supportive comments also noted that the plan was formed through a fair and thorough public process and includes safeguards to ensure that drugs remain available to consumers. There was some general criticism of upper payment limits as a policy tool and some suggested alternatives. First, that UPLs don't address affordability for patients. UPLs may result in certain specialty providers and pharmacies being reimbursed at amounts below their actual cost. Concerns with potential overall disruption on the supply chain, drug shortages and access issues for patients was a common theme of the criticism. And suggestions that there be equal consideration given to non-UPL policy tools, and that the board should be directed to investigate broader issues driving drug costs, including the influence of pharmacy benefit managers and insurer practices. In particular, looking into drugs with high out-of-pocket costs for patients and working with insurers to lower those costs. There were significant suggestions for revision to the plan, including incorporating more specific patient access considerations, defining adverse outcomes and unintended consequences, outlining the mechanisms that would ensure that cost savings actually lead to lower out-of-pocket costs for patients. That was a very common suggestion for revision. There were several comments suggesting that cost effectiveness and quality adjusted life year analyses not be included in any methodology used to set UPLs. Also, there was opposition to using the Medicare maximum fair price or international or domestic reference pricing as a tool in setting actual UPLs. There was a request for exceptions from UPLs for specialty providers who buy and bill and then administer drugs to their patients in their offices. There was a request for a clear and transparent process that would incorporate testimonies from providers and patients, as well as a request that meetings be held either early in the morning or late in the evening so that providers and patients are more able to attend and provide their input. There was a request to include guardrails for protecting confidential and proprietary information that is gathered by the board, and specificity about an appeals process as required in statute to ensure fair and accurate pricing decisions. There's also a note that UPLs should not apply to drugs that have been in shortage at any time in the past 2 years, and ask that the board seek expertise on how UPLs might further counterfeit medication sales. Clearly defining affordability challenges and how they're identified, establishing what criteria needs to be met in order for a UPL to be in the best interest of the state. There was many comments that for seeking additional clarity in the plan, specifically the term of a UPL, whether it will be set through a formal rulemaking process, and what the expert testimony process will be. There was a request that the plan establish what non-UPL policies should be considered before a UPL is applied, and a request that PDAB determine the effect of UPL on Medicaid best price and other statutory and regulatory calculations, and how UPLs will be implemented within the supply chain based on current statutory limitations. Requests that there be a definition of minimal utilization for eligible governmental entities, a request for additional specificity on the type of UPL methodology that PDAB intends to use, and a request that insurers be required to pass on any savings under UPLs directly to patients. And finally, testimony that was more, we would describe as opposition. There was comment that PDAB statute is flawed public policy that will not result in improving patient affordability, that implementation is unconstitutional and inconsistent with the Maryland's Administrative Procedure Act, that the process has lacked transparency, that development of the plan has been rushed, that Maryland upper payment limits could in fact impact federal pricing metrics that determine drug reimbursement outside of the state of Maryland. The plan lacks clear and meaningful standards and procedures to adequately guard against the risk of inconsistent and arbitrary decision-making. Concerns regarding the reliability of the information sources used by the board. Concerns about negative repercussions for access, and a concern that there are not enough specifics about how patient access will be measured. A comment that there lacks sufficient input from clinicians and patients, and that the process has made it difficult for the public to participate. Statement that there is no explicit protection of current cost-based reimbursement for pharmacies, which may disincentivize pharmacies to carry drugs that may have a UPL set on them, which would then in turn reduce patient access to those drugs. Comments that there are problematic assumptions within the cost review process, and that it fails to consider the significant complexity of the supply chain, price concessions, and manufacturer assistance programs. Comments that the plan does not adequately account for drugs with complex manufacturing processes, and a concern that this proposed process may not be agile enough to adapt to novel treatments or pricing models. And that is a brief summary of 77 pages of testimony that you received.
Excellent. Thank you very much, Ms. Chassie, and hopefully everybody has both the testimony and the summaries. Let's now move to questions for either of our presenters. Let's begin with our Minority Leader, Senator Hershey.
Great. Thank you very much. Can you hear me, Mr. President?
Yes.
Okay. Thank you very much. And Ms. Chasey and Dr. York, thank you very much for very in-depth presentation on, I think, to what most people would think is a pretty complex policy that we have in place. But one of the couple questions I have deals with, I think, the basic premise of why the PDAB was created and what we are trying to do. And it in the presentation, and you'd mentioned it, one of the main goals is to identify prescription drugs that have or may create an affordability challenge for state healthcare systems and patients. Dr. York, you'd mentioned in trying to define affordability challenges, the high cost to healthcare systems and high out-of-pocket expenses to patients. Can you elaborate a little bit more on both of those? I think that as we see a little bit on how this is going to be implemented, it might more address the cost to the system rather than out-of-pocket expenses. So I want to just see if you can clarify that a little bit more, since affordability challenge is mentioned so often and is, again, I think one of the key terms in trying to solve some issues here.
Sure. So Senator, thank you for the question. I think the first thing I would respond to is one of the last things that you said in terms of this addressing healthcare costs to the system versus out-of-pocket costs to patients. And I would just emphasize that right now, the way our upper payment limit is set up is that it's a very specific tool to address a very specific problem because it is limited to state and local governments. So just by design, a lot of the state and local government policies that are being regulated, or entities that are being regulated, have very low out-of-pocket costs for patients. The two examples that come to mind immediately is the Medicaid program has a nominal cost of $1 to $3 for patients. And then also, for example, the state employee health plan is one of the more generous benefits that is provided by the state, and is also more of a copay based system rather than co-insurance. So a lot of our work on this front end is going to be saving taxpayer dollars through these programs, and also kind of doing the proof of concept, showing that this policy can work. But the ability to pass those savings on to certain patients when the patients already don't have very high out-of-pocket costs, I think is certainly something to consider. You were asking about just the terms in terms of like the how to determine if a drug is causing an affordability challenge. That's the work that the board is going to do. So as part of that preliminary determination, they would have to articulate why a certain drug is causing an affordability challenge, whether that be high cost to the healthcare system or high out-of-pocket costs for patients. One thing I would note, and this is, again, it just gets kind of confusing, our cost reviews happen at the state level. Our cost reviews are currently in our statute, and what we're looking at is are Maryland patients disproportionately affected. Upper payment limit, again, is a tool in the toolbox to address a very specific issue. So we can still, we're still looking at out-of-pocket costs for the state as a whole. And the board can separately decide that upper payment limits are, for state and local government, is a tool that will help address affordability in the state of Maryland. And then in terms of the definition, the board discussed this a lot. And what they've identified is that there's going to be a number of different types of circumstances and conditions that may cause different challenges, right? So you can picture a drug that is, a new $1 million cure, and that has different affordability implications compared to a drug that is, relatively high cost, but used extremely widely, that then causes affordability challenges to the system. So what the board chose to do is make sure that it's articulating how and why it's making their affordability determination as that part of that preliminary determination process. I think one thing that I also did not address in the presentation is that part of this policy review process is to get more information, right? So they can start with trying to determine, they can start with the work saying, yes, we want to move forward with an upper payment limit based on our preliminary determination. But then as they get more information, they can change their mind there, and they can also change whether or not they deem the drug to cause affordability challenges. I will say there's pretty substantial limitations on the data that's available in this space. So we can collect additional information that can then also, change their overall decision making. So.
All right. I appreciate that. As kind of as a follow-up, and just kind of, this is the season for misinformation right now, it appears. But I think the concern is when we act on anything that deals with prescription drugs, the perception is, at least from the public, that we are doing something that is going to lower the cost of prescription drugs. And in doing so, I think, our constituents believe that they will see the results of this, either through reduced premiums or most likely, I think where they hope, the out-of-pocket expenses that they have to pay when purchasing these drugs. And last year, or last session, we had a bill that was that came in that looked to expand the upper payment limits. It was, subtitled "Lowering Prescription Drug Costs for All Marylanders Act of 2024." So I just want to be clear that as people watch this, as they potentially read about it, that's not necessarily the intention of what is going, or maybe be the intention, but not will probably not be realized as a result of setting these upper payment limits. And even in some of the favorable reports or documents that we got, these are some of the quotes that are based on what would happen. At a time when many government budgets are stretched thin, adopting an upper payment limit action plan would equip our state with the tools to bring meaningful relief. I assume that means to the budget. Vice Chair of HGO even stated that the work must begin to establish upper payment limits so that it can be included in future state and local government contract negotiations, helping alleviate burdens on our state budget. Even Progressive Maryland says we all benefit from lifting the burden on tight government budgets and freeing resources to go to important public services. So in saying all that, I'm trying to figure out, what the message is to our constituents as we're moving forward with this. We have many concerns about taking efforts to trying to drive down prescription drug costs, but it very much more seems like this is a more of a budget maneuver, because it really only affects state and local governments, as you had mentioned previously as well. So what's the message to give back to constituents and people listening to this about how they will be personally affected if we set upper payment limits, if we assume that that's not going to affect accessibility, if we assume that we're not going to see some of the problems that Oregon has faced when they have stopped the reviews that are in process? Colorado has slowed down the process. I believe there's pending litigation there. So tell us why Maryland is going to be different. And again, what can patients expect to see after these are passed when they go to the pharmacy and they buy prescription drugs?
Great question. I would start by reiterating that the purpose of this policy review process is to look at all policies that are available to make prescription drugs more affordable. And those policies that are recommended don't necessarily need to be limited to state and local government. So all the policies that you've seen in the comment letters you've reviewed and that we've heard from our stakeholders are all on the table, and potential tools and recommendations that the board may have. So I think that's certainly on the table. So we do expect that this work can benefit all Marylanders, potentially through our non-upper payment limit policies. And again, we think that those are just as important as the upper payment limits, if not more. For the upper payment limits in particular, the way that the plans are designed that are administered by governmental entities, I think it is true that they have a low out-of-pocket cost for patients, but there are kind of real consequences to extremely high prescription drug costs to the system as a whole, and there are pretty substantial opportunities for savings. So in tough budgetary times, I do think that that's an important point to make. And then also, I think the way that this was designed, because we do have a different scope. I think Maryland is the only state that has the scope for state and local government, is to test the policy concept. It's a very novel policy to kind of test the concept and implement the concept for state and local government, and kind of just show that it can work overall as well. So to that point, I would just say that Maryland is kind of on the cutting edge of trying to address this issue and understanding if and how we can make prescription drugs more affordable. So that's how I would picture this process to work, and there can be substantial savings to taxpayers through this process.
the taxpayers, right? And Mr. President, just one more quick question, because we had talked about the non-UPL policy options, and you had mentioned the same thing, that needed equal consideration. Last year, the General Assembly considered legislation on the accumulator plans. We've also taken a look at rebate pass-through programs. My question is, does the board have the authority in statute to implement any of these non-UPL policy options?
We serve as subject matter experts to recommend policies to other entities. So some could be for legislation, so we can recommend legislation to our partners in the legislature, or some of the action could be done through executive work, for example, different contracting tools and things like that. So we can work with the Insurance Administration and the Department of Health on implementing different policies. But it depends on each policy on how it would be implemented. Very little of it would be directly implemented by the Prescription Drug Affordability Board. But our founding mission was to develop our supply chain report to identify how you reform this market to actually make it work like a functional, competitive market and make prescription drugs affordable and accessible to all patients. So we've developed that document, and that's something that we'll continue to use as a resource that we share when we make different recommendations.
Okay, so if you can't implement directly, could the General Assembly expect that we would see the board taking a decision or making suggestions in its annual year-end report coming up December?
It depends. It's a great question. We do plan to use our year-end report as a mechanism to make policy recommendations. I wouldn't expect anything this year. We proposed to the board, I think we discussed this in maybe our July meeting, and the board decided that just based on the resources available and where we are in our cost review study process, that the board won't have any direct policies this year. But just as an example, we've been charged with drafting a report on the 340B program that I believe is due either in 25 or 26. There can certainly be policy recommendations based on that. We've heard a lot about different kinds of payer issues and PBM issues, including the accumulator issue that you've mentioned. So I would picture that to be a theme of a future report, but probably not necessarily in this year's report. And then the board is always available as the legislator considers different pieces of legislation on providing guidance and feedback there.
Mr. York, thank you very much. I appreciate all your responses. Mr. President, Madam Speaker, thank you very much.
Thank you, Senator. We'll go to Chair Beidel, followed by Senator Reedy.
Thank you, Mr. President. Thank you, Dr. York and Jennifer Chassie. I think one of my questions was just answered, and is the board looking at the influence of PBMs on the cost of drugs?
The short answer is absolutely. PBMs play a central role in the entire prescription drug market. And there are a number of different things that cause affordability challenges, and that's certainly within the scope and interest of the board.
Thank you. And based on the New York Times article that I read yesterday with the closure of independent pharmacies, I was concerned about the comment that this may disincentivize independent pharmacies. Is that something you'll look at more closely, Dr. York?
Yes, the board will look at all potential consequences of their work. And I think we would just emphasize that, we believe that independent pharmacies are an essential resource to the state, and especially, rural and remote communities. So we heavily prioritize ensuring that we have a robust market for pharmacies in the state. And then our plan now is currently specifically designed to avoid some of those risks and challenges. So we've designed it so independent pharmacies should not be impacted in terms of reimbursement as we regulate state and local government.
Thank you.
Thank you, Madam Chair. Senator Reedy, followed by Senator Feldman.
I'll be very brief, Mr. President, because some of the things that I was concerned about have been discussed. Following up on my wonderful chair's comments about independent pharmacies, that's certainly just a parochial concern of mine, representing a sort of suburban and rural area. But I also know our independent pharmacies serve a lot of urban areas where maybe there's not a chain available. So it's the concern, I think, about. Obviously, there's some ideological concerns and things that we bring up from time to time on this issue, but I think here, just very specifically, making sure that if we're trying to save costs, that's passed down in the form of rebates as opposed to trying to reduce reimbursements. And I know, Andrew, you just talked about that, but I don't know if you could elaborate. We want the customers to see the savings. We don't want to see it on the backs of having less choice and opportunity in the market as it relates to where they get their drugs. So I don't know if you sort of talked about, I don't know if you could elaborate
Yeah.
just briefly.
Yeah, thank you, Senator. So we do expect to work with each of the governmental entities that we're working with. So it's hard to commit to exactly how it's going to work for each governmental entity, because again, we have a group of purchasers and payers. So each one will need to be addressed in each specific situation. But I would just say the framework that we're putting forward is exactly what you mentioned, that it won't change reimbursement amounts to the supply chain. It's all done kind of on the back end through rebates on reconciliation. So that's going to hopefully be savings to the payer and their PBM that they would then pass on to patients in those scenarios. So.
And just in closing, I think what you just said about making sure it's passed on, though, is really critically important, that it's not just a savings to the PBM or to the government, but that we're seeing lower drug prices if we're going to weigh in such a heavy way. But thank you, Mr. President, and thanks for the answer.
Great. Thank you, Senator. Chair Feldman, followed by Chair Pena-Melnick.
Thank you, Mr. President. And I don't know if it's for Andrew or Jennifer, but so we were the first state out of the box, but then Colorado followed suit, shortly thereafter. And as Senator Hershey mentioned, there is lawsuits or litigation that was filed this year on that. So Andrew, you mentioned our model was pretty narrow in scope, state and local government, and then also it did limit your authority to directly do something. It's largely recommendations back to the executive branch, to the General Assembly. But that said, always worried about lawsuits slowing things down. I don't recall, and I apologize if it's been, has the AG, even with our more limited, and we are set up different than Colorado, but their, lawsuit is about supremacy clause, preemption, all kinds of stuff. Do we have an AG opinion actually scrutinize some of the arguments in play in Colorado and how they might apply to our PDED model just as we move forward here?
I may defer to DLS because there was an original note when the bill was passed in 2019, and I think all these issues came up at that point.
Right.
But it's certainly something that we are looking at, and we think that we're following a process that would address most of the concerns that are coming up. So I think we're aware of the different challenges that we may be facing, and we're working very carefully to make sure that we are staying within the legal limits and scope of our statute.
Okay, look, I appreciate that. I guess it would be comforting to at least have something formal from our Attorney General's office, confirming that at least where we are now is, we're taking into account, at least we know the arguments that could be coming down the pike, and I just think it would be helpful. So with that, Mr. President, I'll yield back to you.
Thank you, Chair Feldman. Chair Pena-Melnick.
Thank you, Mr. President. I'll make this really quick. We know that prescription drug prices in the United States are significantly higher than any other nation. And we don't have any central negotiating authority, which is why the federal government has started doing the work. So how would the recent Medicare maximum fair price negotiation impact this work, Mr. York?
Great. Thank you, Chair Pena-Melnick. I would say that the Medicare work is kind of another, going back to the term proof of concept. It's showing that this work can happen. And we do directly reference their negotiated maximum fair price in our work, saying that our upper payment limits would never go below a maximum fair price that has been negotiated. So if we select a drug that has been negotiated on Medicare, we would not go below that price. And that also provides an opportunity for reference pricing. But I think, again, just going over to the overall premise, when we first started in 2019, there was nothing really to point to. And now we get to look at our colleagues in the federal side in Medicare and some other states and just understand that this process can work and can provide savings.
All right. I do not see any further questions for our presenters. Let's see if there is a motion to be considered.
Yes, Mr. President.
Yes, recognizing the chair.
Thank you, Mr. President. I move that we approve the upper payment limit action plan approved by the Prescription Drug Affordability Board.
All right, Chair Pena-Melnick has moved the approval. Is there a second?
I second, Mr. President.
Okay.
We've a double second, a second on the third. The motion.
I doubled that second. Yeah, that was
yes,
me.
excellent.
Right.
Are there any discussion on the motion? Discussion on the motion. Question before the body is whether we will approve, a vote yes would approve the upper payment limit program process as described. A no vote would be to reject it. Any further discussion? If not, if we could have a member of our DLS team, please call the roll.
President Ferguson,
Yes.
Speaker Jones,
Yes.
Senator Augustine,
Yes.
Senator Beidle,
Yes.
Senator Feldman,
Yes.
Senator Gazzoni,
Yes.
Senator Hershey.
Yes, and Mr. President, if I could just quickly give an explanation, please. I think we've had enough conversations, certainly in Senate Finance, and trying to find ways to lower prescription drug costs for the patients themselves. Unfortunately, I don't think that this process works, so I'm going to vote against it. And I say that because we haven't seen this work in any other states. In fact, the two other states that have adopted similar policies have both put their process on hold. We are talking about this as though patients and customers will see some type of difference when they go to pay for their prescription drugs. And again, that's not the correct message that should be going out as a result of this. There are concerns about accessibility to prescription drugs, as different manufacturers talked about, if they were limited to what their costs could be. And I think that could be a very detrimental result of this. Mr. President, I just feel that this seems to be a rush to pass this, so we could look at legislation like we looked at earlier this year. I think the board has done good work, but I just don't think that they have done enough work, and for that reason, I'm going to vote no.
Senator King,
Yes.
Senator McCray,
Yes.
Senator Reedy,
No.
Senator Zucker,
Yes.
Delegate Atterbury,
Yes.
Delegate Buckle,
No.
Delegate Clippinger,
Yes.
Delegate Lewis,
Yes.
Delegate Moon, no. Okay. Delegate Pena Melnick,
Yes.
Delegate Pippi,
No.
Delegate Rose,
No.
Delegate Shetty,
Yes.
Delegate Stein.
Yes.
Did I miss anyone? Delegate Moon? Thought he was present. Okay, so let's see here. And let's see, 1, 2. So sorry. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. 16 in the affirmative. And 1, 2, 3, 5 in the negative.
All right. Thank you very much for that. So by a vote of 16 in the affirmative and 5 in the negative, the motion passes and the plan is approved. Thank you all so much for your time and attention and thoughtful discussion today. This is a complicated issue, and appreciate the presentations as well as members' participation today. Madam Speaker.
Okay. Well, this is just some closing remarks. In listening to everyone, I look at it this way. Today marks another step in what has been a deliberate and transparent 5-year process. I'm confident that the board and its staff will continue to listen to everyone involved as they implement this action plan. We can and must make some prescription drugs more affordable without upending the marketplace. And I'm going to close out by thanking everyone for their hard work on behalf of Maryland taxpayers. And I look forward to future reports of our progress. And that's how I'm closing. Thank you.
With that, thank you all very much.
Thank you.
Mhm.